Hello, welcome to the International Interprofessional Mentorship Meeting. I am Dr. Kate Ballo, the founder of the program and your host for today's meeting. It's September 24th, 2020, and today Dr. Paula Rabaey is here to talk pediatric feeding. Please mute yourselves during the presentation and unmute yourselves whenever you would like to ask a question. You can also type your questions into the chat box and I will ask the questions for you. In order to receive a certificate of attendance, please enter your name and email into the chat box now, and you will need to remain on the webinar until the presenter is finished. At the conclusion of the presentation, we will have an optional meet and greet. Thank you all for coming today, and we can get started. Thank you, Paula, for coming.
Thank you for inviting me. I was very excited to find out that my friend and colleague, Kate, had started this group. We first met, virtually and were roommates at the last WFOT conference in South Africa. And then she accompanied me to Ecuador with some of my students. And now we're working on a grant project together around feeding. So thank you. I'm going to tell you, I'll just give a little bit of background just to situate where my experience is. And again, I do not claim to be a feeding expert. I can share the knowledge that I have gained and would love to hear all of your experiences as well. So I have worked in pediatrics for, I think, 27 plus years now, but I've been in academia. This is my 13th year in academia at St. Catherine University, located in St. Paul, Minnesota. And I started working with feeding issues right out of the gate in one of my first level 2 clinical field work, and had a great mentor and was hooked. I just happened to be in situations where there wasn't really another OT or speech person available. I worked in rural Minnesota, so gained a lot of skills. Have worked with kids from babies all the way through their transition to adulthood, but my feeding experience primarily is from kiddos that are like 0 probably till 10. So a lot of work, I did a lot of early, of my clinical work in early intervention here in Minnesota. So I've worked with a lot of different conditions from autism to CP. I would say my most experience is with kids with neurological disabilities, but also those kiddos with sensory issues like autism as well. I am part of SPOON Foundation, which stands for Supporting Overseas Orphan Nutrition. You can look them up at spoonfoundation.org. I got involved with them. They support children living without families, so living in institutions or other care settings, with disabilities and feeding. And well, actually all kids in orphanages and nutrition, but particularly got involved with the kids with disabilities living away from family care in a lot of different countries. So I have done some work for them. You'll see an example of an assessment that I have created that I'm hoping I will get feedback from you on tonight, and would love to partner with some of you on it. And I have worked in about 8 different countries with caregivers, including those who are caregiving in orphanages and other centers where children attend away from home, as well as families. And so I bring to you just the experience that I have from all walks of life. So I've done a lot of training with SPOON Foundation. So it's hard to get all of feeding into an hour or 45 minutes. So I have a lot of slides, and some of them I posted just for your information. I'll go through them quickly, but it's things that I would like just as reminders to keep in mind. And this is designed to really just look at feeding practices in general that are evidence-based. So the objectives are just to demonstrate an understanding of how feeding practices contribute to nutritional deficiencies in children with disabilities. That is something that is very common here in the US, but something that I encounter, that almost always is encountered in the children that we're working with in orphanages, other care centers, or that are living in low-resourced countries and don't have a as good of access to healthcare. So we're going to talk about how that really plays into their disability. And really, the main key for tonight is to understand the evidence for current best practice in feeding children with motor impairment and other multiple disabilities. I'm going to present a model of feeding that is very holistic, and we'll go through some areas. And then just to hopefully increase your knowledge related to some feeding practices with children that you can take back with you and implement right away. So again, I tend to talk really fast, and this is a lot of information, so please put your questions in the chat box, or if you want to talk in more detail about a certain concept, let me know. I realize there's probably more than, there might be speech therapists on here, I don't know, but I wanted to just pull up a quick slide that talks about OT's role in feeding, eating, and swallowing. A lot of times in my career, I've gotten countered and saying, well, how come you work in feeding? I thought that was speech's realm. And it's very interesting in many of the countries I have worked in. They don't have OT. There is no OT program. So I'm working a lot with the speech language clinicians there. So, but what I wanted to just emphasize on this slide is that feeding, eating, and swallowing, they're all interdependent, but they're part of the larger occupation of mealtime. And so it's so complex. There's the motor, there's the sensory, there's the cognitive piece. And then there's also the relational piece between the child and their caregiver and family. And what I have learned that is very, very important to always keep in mind, whether you're evaluating or working on an intervention with a child with feeding problems, is to remember that everything is influenced very strongly by psychosocial, cultural, and environmental factors. So the first slide I'm going to go through is just kind of talking about, again, I think this is so important, and something that I've learned and have done a lot of training with in other countries is that our children with disabilities, who have disabilities and a feeding difficulty, are our most vulnerable children and at incredible risk for malnutrition. And I think that's an important point to keep in mind as we're working with them. So there is, I mean, the literature will say there's approximately 30 to 90% of children that, with disabilities with significant motor and or cognitive disabilities that also have feeding difficulties. If you're talking about the classification of cerebral palsy, that number is close to 80 to 90%. And those problems can include dysphagia, which is difficulty swallowing, oral motor, sensory issues, food aversions, coordination problems, and aversive feeding behaviors. And our children with more generalized CP and intellectual disabilities are especially at risk for dysphagia, which has significant health consequences, particularly depending on what part, where they live, what their resources are. That can lead to death. So things like malnutrition, aspiration, and caregivers just struggling with the stress of feeding. So we have the consequences of that is that we have these children with disabilities that are chronically undernourished or have malnutrition, a lot of stunting and wasting, which early on significantly impacts brain growth and development. And so feeding is so important early on because it impacts all of the other development that that child does. And some of the most common micronutrient deficiencies that I've seen here and in many of the different countries I've worked with include iron, number one, anemia, calcium, vitamin D, and vitamin C. Okay, so you guys probably all have encountered different disabilities that impact feeding. So these are just a few of them. So anywhere from our babies who are born prematurely, neurologic disorders is a large category, but even children that have respiratory and cardiovascular problems. So our kiddos that are born with a congenital heart problem often right off the bat have trouble sucking and just don't have the energy to do and endurance to do so. So just to know that there's a lot of different disabilities that impact feeding, and there's a lot of different feeding problems. And these, again, can go from inappropriate behaviors, which we see with a lot of our children on the autism spectrum, lack of self-feeding, Failure to advance textures from puree to table food. That's very significant in a lot of our kids with neurologic disorders. Oral motor immaturity, aspiration and swallowing, and gagging and vomiting. So important to know that we want to, no matter the diagnosis, there still could be feeding problems. And even if some of their condition has resolved, the feeding problems can still persist. So I just put this slide up because I think it's super important, and it shows the cycle of how feeding difficulties get exacerbated. And you can see in the green circle I have parental anxiety, but you could substitute that for caregiver anxiety, because there is a lot in many different circumstances. That person, whoever is the primary feeder, it can be the caregiver at their school, in the orphanage that they live, it could be grandma, it could be auntie. But the number one thing that I see is parental stress and anxiety, and even anger, because parents associate feeding their child with nurturing. So I'm a successful mom if I can feed my child, if I know that I'm giving my child healthy foods, right? I know they're getting sufficient quantity and they're growing, okay? So always have to work with the caregivers and the children. And feeding difficulties can cause this vicious cycle that impacts the child and family quality of life. And that's a lot of what I've seen in work around the world, is that it's not only the child quality of life, but it's the family quality of life that is reduced, because we have this cycle of poor feeding. So maybe it's dependent on skill. That may lead to the child's refusal to eat, which is then, if you don't eat, you don't get to practice, you lack skill development. So there's no opportunities to practice. Then you don't grow very well. Now that starts to create real caregiver anxiety. More caregiver anxiety can lead to poor feeding and food refusals again. So it's very vicious cycle. So we're going to talk about some of the principles of intervention are giving the child lots of opportunity to develop skills. Okay, so these are kind of some of the points that I just want to make. And I think is when you go into, or you have a child come to you, or you go to a home and you are first starting to look at feeding difficulties, always keeping in the back of your mind that nutrition and disability are closely linked. And if I have a child who's not getting enough nutrients, it's going to affect their engagement in learning. They're going to be tired. They're not going to want to engage. They don't have energy. And that those nutrient deficiencies can also cause more disability or worsen the disability that they have. Oftentimes we have to look, there's a lot of oral motor and swallowing difficulties, even with kids that we think only have sensory difficulties, and that the increased stress is on both the child and the caregiver, and that interaction needs to be observed as part of the assessment and treatment. And I think I can't emphasize enough, some of the nutrition pieces is made worse in low resource countries where food insecurity is a problem every day. Or I've seen it here when I've worked with some of our immigrant population. Always need to assess what the family's food availability is. So this, there we go, pulls all up. Okay. So I like to use this visual that shows how nutrition and disability interact throughout the life cycle. But what happens is that we don't often link this in the work and in the students we teach, in the conversations we have, and we need to link it more in global health conversations. So we talk about nutrition to prevent education, but we rarely talk about nutrition for those who already live with disabilities. So it's really important, I think, to address. So I'm going through that part rather quickly. We could spend a whole afternoon on nutrition and disability, but we'll come back to it when we talk about food and food textures, and how some kids, when they get limited by food texture, it leaves out all the nutrients. So our goals, or the overall goals of treatment of pediatric feeding problems, should include improved health of the child, also improved quality of life for both the child and the family, which is linked to decreased mental health problems in the family because there's a lot of stress and anxiety. And we want to reduce the risk of long-term feeding difficulties. So we want to work with children early because ultimately that's going to reduce healthcare costs. And even thinking about some of the children that I've worked with, working with training the caregivers actually in orphanages, we link it to that child will have less respiratory illnesses. They'll get sick less. They won't have to go to the hospital. And that's a big deal for some of our families in different places around the world, is that kids with feeding difficulties just have this increased risk of a lot of different health problems. So we want to reduce healthcare costs. Okay. I don't think there's any questions yet, but if there are, please stop me. Okay, so that's kind of my broad overview that sets the stage for the model of pediatric feeding that I really like because it's very holistic and it fits in with the new definition of pediatric feeding disorders that is being worked on. So, and how I'm going to present the interventions and assessment is in each of these areas. So we have, the big one in the middle is oral motor dysfunction. That often is the first thing that starts. There's a lack of coordination. You often see it when they're in bottle feeding, and all around there, things that can contribute to that are the oral motor issues, which we'll talk about. That's like control of the tongue, lips, jaw, everything. Linked to that is impaired postural control, which we're going to talk about. That's a huge evidence-based intervention. I'll talk a little bit about what in the yellow is what's called state issues. And when I talk about state issues, this is really the kind of state of self-regulation the child is in. It's their awake state of arousal, because what the child's state is, when they have a calm, awake state of arousal, it's been found to have a positive effect on, for sure for babies, for their sucking ability and feeding. And so when I work with the little ones, the babies, a lot of times it's working with caregivers to read the signs of the infant readiness for oral feeding, which we call cue-based feeding. And when caregivers can effectively read the signs of infant readiness, it's found in literature to be very predictive of feeding efficiency. So, and the reason we talk about state is because a lot of our children with neurological issues, certainly our kids with autism, become upset and agitated very easily by either environmental or sensory factors or the texture of the food. And that dysregulated state exacerbates their feeding problems, which is closely linked to the light blue sensory issues. And then there's also in the green, we want to talk about systems issues, which is everything like, I talk about like gut issues, so that's mostly cardiac, respiratory, and gastrointestinal. And then the big one is swallowing, which is linked to the oral motor and the oral dysfunction. So we're going to use this model as we go through the rest of the talk. Okay, so some of these I'm going to talk through quickly because I want to spend the most time on swallowing, oral motor, and impaired postural control. So, but I want to just highlight systems for a minute because these are some of the things that, like early on as a pediatric therapist or a new therapist in feeding, I didn't really think about. And we know more information now about gastroesophageal reflux, and a lot of problems that kids can have with digestion. So we want to just be aware of, to make sure that some of the problems that our kids or babies are having isn't linked to gastrointestinal issues that can be helped through a doctor. So thinking about, because a lot of those issues cause discomfort, nausea, and lack of hunger for our kids, which all interferes with feeding and the parent's ability to feed and feeding intervention. Most of the time I've had to even stop therapy with a child who has unresolved gastrointestinal issues, because we don't get anywhere with feeding therapy because they're just not hungry and they're uncomfortable all the time. So one of the most common that I think we deal with is gastroesophageal reflux. And that's where they're regurgitating the acid, and that's what's very painful. So one of the things that we can particularly pay attention to is the amount of spitting up or vomiting a child does. And this can help us think about the position we place kids in for feeding and keeping them upright after feeding so that they're less uncomfortable. Okay, state issues. Again, I'll touch on these briefly, but we can talk about them again in sensory. This would be a whole nother webinar, I think, by itself. But this is, again, just taking stock of when you watch the child and the caregiver together in feeding session, what does it look like? Is the child calm and comfortable, or are they crying, arching their back, throwing their head around, and that just exacerbates that stress cycle. So we want to make sure that we have a good state of arousal, particularly for our babies, because it has a very positive effect on their sucking ability and feeding. And so a lot of the work we've done around this, particularly for babies living without families, is being able to read their cues, positioning, swaddling, and just paying attention to the environment. But it's important to address because a lot of it is environmental factors. Okay, those two I'm going to go over fast. Now, let me know if I'm going through any of this. Some of this is probably review, but it's important points that I want to emphasize. If there's anything as we go through swallowing that you want me to touch on in more depth, let me know. So we're going to focus on that area of swallowing because this is a big issue in many of our kids. And causes of swallowing difficulties can be neuromuscular or neuromotor and anatomical. And it's not just our kids with cerebral palsy, it's our kids with other conditions like Down syndrome, who are born with more lower tone, kids who are babies who are premature, and again, their system isn't as developed, their muscle tone is low. They often have difficulty swallowing right off the bat, and that leads to a lot of problems that quickly can exacerbate. So in the slide, and I told Dr. Barlow that I sent the PDF and she can distribute it to you. I included a picture of just a review of important anatomical structures, just to know the landmarks, and the ones to note are like the tongue, where the hyoid bone is, because that's very important when we're doing some of our positioning, showing caregivers how to do some jaw control. We want to make sure, one of the biggest things is we want to make sure that the caregivers aren't pressing on the child's hyoid bone, because that impairs swallowing. You want to know where the hard and soft palate is, because that important for triggering gag reflexes, and knowing to be able to explain to caregivers the trachea and the esophagus, because that's how we can explain like aspiration, what we say when food's going down the wrong way. So it's important to think about, I always think, when I started going to feeding continuing education courses, it was all about anatomy, and it wasn't something that I got a lot of in school. So I do emphasize, if you work with a lot of children that have swallowing problems, that you learn those, that you memorize those anatomical structures, and that you learn the 3 phases of swallowing. Because kids can have and adults can have problems at any one or all of those phases. And then treatment can look a little bit different for each one. So just quickly in review, phase 1 is the food is now in their mouth, so they're gathering it. So this includes even like being able to open your mouth enough to get the food in, and how that child forms it into what we call the bolus, which is get the size they need to swallow it. So in order to do this, they have to have adequate skills to be able to suck bite, mash, or chew. And they need to be able to hold that bolus in their mouth so that it has a timely release backwards for swallowing into the pharynx. We see a lot of issues with oral phase 1. I'm sure you all know the kids who they immediately lose the food back out of their mouth. They have a powerful tongue thrust. They lose a lot of liquid. They're not able to keep their lips closed. And so, and this is all the oral phase is all about using your teeth for solids and how you can use your tongue to actually move it in your mouth. So this is a lot of what we have done. We do intervention with in oral motor skills. Phase 2 is now the food or liquid is moved to the back of the mouth to prepare for swallowing. Phase 2 and 3 start to happen fast. So in phase 2, they've got the food's all ready, and the tongue is the most important structure in this phase. So inadequate tongue movements from either restrictions anatomically or oral motor dysfunction alter the ability to swallow without compromising the airway. And when you see, often you can tell children who have problems in this phase of swallowing because the coughing and the choking, because things are going down before they were ready. Phase 3 happens automatically. In this phase, the swallow reflex is triggered and the food or liquid move into the esophagus, which goes down into the stomach. This phase is important because this phase includes airway protection from aspiration. So in order for this to effectively happen, the nasolaryngeo and oral openings have to close off so that the food or liquid goes down what we call the right way. So kids who have trouble in this phase, sometimes you might see food or liquid come out their nose. You're going to see that choking again. We've all experienced this when we swallowed liquid or something down the wrong pipe, and we want to know that their airway's being protected. Otherwise food can get into the trachea and lungs, and this is where we get the consequences of aspiration, which lead to pneumonia, chronic respiratory distress, and oftentimes death for some of our children. So just kind of as you're watching a child eat, observing is a very important part of intervention for children or for feeding. And so it's important to kind of watch and see where the child is struggling, if they're struggling at one particular of these phases or all of these phases. All right, I'm watching the time. Okay, so swallowing difficulties. Again, these are just some of the things. Issues, a lot of it is issues of timing and oral control difficulties. But safe swallowing is important for health and good growth and nutrition. So we want to pay attention. And aspiration can be a combination of all of these things. So I'm going to kind of skip over that. Okay, and we're going to go into some of the treatment evidence that I'm going to go through. So this is based on some literature reviews that I've done. I do have a published critical review on feeding children in institutionalized settings, but the evidence that exists in the literature is around posture and positioning, diet modifications, which means texture. So texture modification of the food, the type of equipment and utensils we use, oral motor treatment, and then around what we call pacing and cue-based feeding or responsive feeding. So going back to diet modifications, that refers to not only the texture, so texture of food, but the viscosity of the liquid, is it thickened, how fast does it flow, and also the portion size. How much are we giving them at once? Are we using the appropriate size spoon? So the most important one, and one that we always want to start with, is posture. So our kids often have impaired postural control, and it all starts with pelvic stability. My favorite saying that I learned at a long time ago at one of my continuing education courses was, what happens at the hips shows up in the lips. So we always want to start with the pelvis or hips. So you can see the diagram here is kind of the order of where we should really look at things. We often want to start with the head, but most times if we make those small adjustments in their pelvis, and depending, you know, even if it's in the caregiver's lap, if it's in a chair, if it's on the floor, it's going to automatically change their trunk and head control, which gives them more jaw stability, better tongue control, and better lip mobility. So we want to build that foundation for posture so that they don't have to work so hard to hold their body upright, but they can use their oral motor structures for chewing and eating and swallowing. So it's all about giving stability. This can be done in a lot of ways. So this is a diagram from one of the trainings that I use. So we want to have good positioning and feeding because it leads to safer feeding in terms of swallowing and manipulating food. It leads to better efficiency on the part of the child to be able to chew and swallow, and it gives them more stability. So safety, we want to decrease their risk of coughing, choking, or aspiration. Efficiency means we want the child to take in the appropriate amount of calories, okay? A lot of times these kids, the caregivers are saying, I'm feeding them for 45 minutes, but if you actually look at the amount they ate or drank in 45 minutes, it's not nearly enough what they need to maintain, much less gain weight. So we want them to take in the appropriate number of calories in the right amount of time and without burning too many calories on top of it. So we want to think about upright positioning. Now, the gold standard always is, we hear 90 degrees, 90, 90, 90. The hips have a little wiggle room. And a lot of the kids that I've worked with, particularly that live in institutionalized settings, have a lot of bony contractures, and their hips do no longer get to 90 degrees. So we know that we have some room between 70 and 90, but we can also keep a child's hips at 90 degrees and then tilt the chair. So we want to give them as much stability as possible. Feet on the floor or supported. A lot of times if it's a little one and the caregiver's holding him in their lap, I say put their feet right on your leg for stability. You want to make sure their head is stabilized and supported enough so you can get that slight chin tuck when they're chewing and when they swallow. So these are the principles and recommendations. And there can be a lot of different things that you can use to help position. I've been in a lot of places where they don't have specialized chairs or anything. So as good OTs, we are creative and modify. But you want to remember the principles of proximal stability so that you can get stability for head and neck in midline and the child is comfortable. Also the caregiver, which I'll show on the next slide. And these are some of the recommendations. And you can use anything to secure hips, a scarf. So you want to think about securing the hips first, some sort of side supports, which blanket rolls and towel rolls are always great. Keeping their hands at midline. I don't have my baby doll here at home, even if they're in your lap. And some sort of support for their feet and their upper body. So this is where I'm this is in the process of getting copyrighted, but in the assessment that I developed with Spoon that I now have ownership of, it's a quick assessment. It's of how a caregiver is feeding a child. So there's a page on how you can assess bottle feeding positioning, and this is for a baby that is still breastfed or bottle fed under the age of 1, and they are held by a caregiver when that's happening. So this side is you want to look for certain things like, is the baby's head in the middle? Is the baby's chin down? Is the baby's hips lower than their head? Is the caregiver supporting the arm? Yes, no. And then what we tried to make unique about this assessment is if you get a no check mark, then there's some things to try. Okay, so if baby's head isn't in middle, we want to help the caregiver adjust their position, to help support their head and present bottle with the baby's head in midline. Also included in a box about do no harm. So things, and these are things that I have seen around the world. We don't want to lay baby flat with the bottle propped because that leads to choking and chronic ear infections. And one of the big no-nos that we've done a lot of education on is no cutting the nipple, which frequently happens for older kids who haven't transitioned to a cup, or they're putting the thick soup or pudding or something in a bottle with the nipple cut. What that doesn't do is it doesn't promote any skill development on the level of the child, because it just, the food can just come in their mouth, and usually by gravity, it's just going down their throat. Same thing. This is assessment of feeding positioning for children who are eating solids and drinking from a cup. Now, whether they're being held in a caregiver's lap, or they're sitting in a chair, or sitting in an assistive device, these are the principles that we just talked about. So going down the line, looking at hips, trunk, shoulders, head, knees, feet, and things to try. So again, the big one is the hips. If your hips are not in a proper position, you want to use some sort of belt or strap or scarf. And you can also put a small towel roll under their thighs, and that kind of helps bring it gives them that little bit of pelvic posterior tilt. I mentioned that caregiver position is also important, and we have found this a lot with our caregivers in institutions and families who are in low-resourced areas that don't have any kind of other seating place to put their child other than the ground, but yet that child is as long as a 7-8-year-old, so it gets a little tiring to hold that child, particularly if they have a lot of muscle tone or spasticity. I'm sure a lot of you have experienced that. Those kids can push really hard against your arm, and it's super fatiguing for the caregiver. So these show some modified positions for caregivers, and my favorite one here is, I don't know if you can see them here, but I like this. You can make a little bucket for the child's hips and pelvis. You can see the child's hips are still in 90 degrees, but they have a little tilt in space effect, but yet the caregiver's arm is supported enough to have that baby's or child's head forward in a slight chin tuck. This one over here is a caregiver sitting against a wall. That one works really well. You can prop and you can put a pillow under this kind of bent leg. Tuck the feet under, because that is especially helpful for kids with a lot of mixed tone, fluctuating tone, or they're flailing or spasticity, because it gives them some stability. And then here's a picture for breastfeeding. So we want to make sure that we're not only addressing the position of the child, but of the caregiver. Okay, so here's where I want to just hear from you guys for a little bit. So here's a couple of pictures of kiddos. So the picture, I guess it's the child in the high chair. What are some things that how would you go about, or do you see any problems with his position, number one, and what would you do?
Hello, guys.
Hello.
Yeah, my name is Emmanuel. For the kid on the right-hand side, no, on the left-hand side, his head needs to be in midline position. And also, like, the caregiver, if he has sort of spasticity, maybe he can, there's a way he can hold the hands so that there won't be any fluctuation.
Yeah. Yeah, so the way that is, are you talking about the child in the chair?
Yes, yes.
Mm-hmm. Exactly. So that child, you can tell their hips are probably off. They're not facing forward, so that's making their whole body go off, which is very important. You can see in this picture the influence on the head and neck. It's causing their head and neck to go to the side, which is going to make it really hard to chew or manipulate the food once they get it in their mouth.
Yes. And for the second picture, like for the example you showed, the mother should create like a bucket, kind of. The hips are not in 90 degrees, kind of, and the head is not in a chin tuck kind of a position.
Yeah, this is a picture where like the caregiver is got the right idea. And if we can just help the caregiver shift the child's bottom a little bit more into that kind of little bucket that is made between their legs, and that would allow the caregiver to bring the trunk and head up a little bit more and into more chin tuck, because when I watched them feed this child, then what happened is every time the spoon touched that child's lips, they arched their head back. And she didn't have enough support to prevent that from happening.
So I think this just shows the importance of positioning in pediatric feeding. Just
yes,
the slight
thank you.
changes makes a lot of difference.
It does, absolutely. Thank you. That's why I always start with the position, because even just modifying the position a little bit, you get a much better, it's hard to tell what a child's actual skills are with their food, with their oral motor structures until they're in a good position. So for example, the kiddo in the high chair looks like maybe they could benefit from some side rolls because it looks like they don't have a steady trunk control. So that could give them a little more stability. And then maybe they need a strap or scarf at their hips to hold their hips back, and then I bet that it would eliminate the need for them to have the scarf tied around the trunk and arms. Great, thank you. Anybody else have any comments? All right, I'm trying to go fast, Kate. I'm looking at the time. So, okay, so this is the other big one I'll spend time on. So we get the child's position. Now we can look at what's going on in the mouth. We want to look at oral motor issues, which include the function of the jaw, tongue, lips, and cheeks, kind of separately and all together, because those structures and how they work affect the child's ability to feed efficiently and safely. So we want to particularly watch the tongue to see how it gathers and moves the food, or are they always in a tongue thrust position? Do they have any side movement? Or do they have very little movement in their tongue at all? Lips, you want to pay particular attention to whether that child can use their lips to clean the food from either the spoon or the caregiver's fingers, because caregivers also feed with their fingers, or if they're able to put their lips on the cup and draw liquid in from the cup or the bottle. And then you also want, once the food is in their mouth, you want to look at, can they hold their lips shut? Do the lips actually have any active movement to keep the food in the mouth? Jaw, we want to look at how the jaw provides stability, okay, so that the other structures can do their job, okay? And its primary purpose is to chew the food. So we want to watch how much jaw stability. Some kids have a real, I call it jaw thrust. They don't have good control over it, and they don't have any, their jaw can only go up and down, so they only are able to kind of munch food, but they don't have a rotary chew, so they can't chew textures beyond something soft. And then we want to watch the cheeks, if they're keeping the food over the teeth for chewing, or if the child's food is just getting lost in their cheek and they're not able to clean it out.
Paula, can I interrupt you real quick? There's a question in the chat box, and Nora's wondering why there is a rope around the child's arm rather than just the trunk.
Oh, good question. That we hadn't done. This was from a setting where a child was living in a without family, and oftentimes caregivers are doing the very best they can with what they know. And so they knew they had to give this child stability, but this child had a lot of tone and moved around. So their thought was, well, if I can keep the arm from moving around, then I can get this child fed. So they were attempting to give the child stability, but just needed a little more coaching on maybe the right place to put the strap. Not so in part of our training, and we were there for like a week, we helped them modify position by moving the strap more to their trunk versus having them hold their arms down. And I do want to emphasize that point that caregivers aren't doing, some of the practices we see aren't because they want to harm children or they know it harms children. They are trying to be creative in their head and do the very, very best they can because they are caring for a lot of children. Okay, so thinking about this slide just tells you about, so we want to look at these structures. This is just a slide that tells you at approximately what age the movements that a child has with their tongue, lips, or jaw. Okay, so we look at, if you're looking at a 6 to 9 months olds, really just still have that forward and back tongue movement and up and down. They don't have a lot of side to side. And so this is a good slide to keep handy because it helps us assess like where the child is at. Even if that child is 5, we can look at kind of what age their skill level is by knowing at what ages from about 6 months to 2 years that tongue, lips, and jaw skills get more what I call refined. That's the word I was looking for. So, and the important thing to remember is we want to match the child's ability to move their mouth to match the ability to move their mouth match the ability to move their body. So it often goes hand in hand. So if I'm seeing a child whose oral skills are around a 6-month-old, usually their motor skills, both gross motor and fine motor, are also at that level. And then we want to start to match where the skills are. So let's say they have skills here. Now we need to match that to the texture and type of food that child eats, which is what this picture shows, feeding skill development. So we can kind of think about sitters, crawlers, walkers. A child needs to be, a child who can sit relatively independently is going to still be in a puree texture. A crawler has moved to more of a mashed, and a child who has the motor skills to be an independent walker can eat small diced foods. And this is helpful I think this is a helpful visual for working with some of our caregivers, because we need to emphasize that feeding skills are learned over time, and we can only advance a child's diet successfully when it's done with a child who is ready to consume the type of food being offered. So we always have to remember that our ability to move our mouth matches our ability to move our bodies. And this is something that it's very helpful to talk to caregivers about. So advancing a diet should always be done based on developmental readiness, not on what their real age or diagnosis is. Okay, I'm gonna move on. So these are just things, and you've probably all seen them. I'm gonna skip over these slides. These are oral motor concerns with liquid. I'm sure you've seen them. They have a disorganized suck swallow, lose liquid, cough gag. This slide talks about oral motor concerns that we often see with purees and solids. A lot of it's the incomplete first of all, they can't grade their jaw. So sometimes they don't know how far to open their mouth when the spoon comes. Some of them open it too far. Some of them they have such tight tone they can't open enough. They can't clean the food off the spoon or their caregiver's hands, pocket food, that tongue is not moving it around. So those are a lot of common issues. This again, and I can stay for some of the meet and greet, this is a sample quick screen of one of the pages of our assessment that looks at cup drinking. We have pages for a page for cup drinking and one for spoon feeding. And so some of the things that we want to look for, part of it's how the cup is presented to the child from the caregiver, but then you can see that we also want to know, does the child swallow without coughing or choking? And then if there's a no again in that category, we go to the if no, try. So for coughing and choking, one of the first things is we want to look at their position and make sure we're supporting their head with a chin tuck and giving them enough jaw and lip support. Okay, so again, we want skill development in our child, and that often, and that's related to opportunity. Some of our kids just don't have the opportunity to practice, And practice is what builds skills. If you think about babies or kids in your life, how much practice they get, you know, they practice and when they're crawling, rolling, sitting over and over. And at the same time, children practice how to eat from a spoon, drink from a cup, how hard to bite into different textures. So they need opportunity to practice, which is important to talk to caregivers about. So this slide is probably the important one, and I'm going to demonstrate a couple of these techniques. I have my little spoon and cup here. So this is a chart. So these are feeding techniques for children with disabilities, and this one is for kids who are drinking from a cup or eating solids from a spoon or a caregiver's hands. This chart. There's another chart I have for babies, but these are some on the observation side. You'll see some of the very common problems that we see with a lot of our children. So for example, if you have a child who always loses the food or liquid, whether it's because of tongue thrust or not enough lip control to keep the liquid in their mouth, then we have a technique on the far right side, and that technique is jaw lip support. And I'm going to go back a little bit, because on this page here, you will see these pictures on the bottom. Number 3 is how to give jaw support. So for example, my favorite cup is this cutout cup, but in a lot of places where we can't get these, and most countries, they might have their own, but it's hard to import. Institutions don't like them because it's hard, they don't run very well, they melt in a very hot washer. But you can make one really easily from paper. So for a child who's maybe their head is all over, that can't control their jaw, I give them, now again, make sure your thumb is on the chin bone, not on the hyoid or blocking their swallow. And you can give them that jaw support as you are feeding them. So imagine I'm holding a head right here, and then I would be giving liquid. You can also do it from behind, which is number 2, which is oftentimes for children who are bigger and they're sitting up in a wheelchair or some type of chair, and I can give them a lot of head control with my elbow and use my shoulder. So that's what I mean by jaw support. And you can do the same technique with a spoon. I'm going to go back to our little chart. Okay, so when a child, so this is oftentimes, and this is a learned behavior, children who tilt their head back when they get a drink. It's often because that's what they've learned to do to swallow, because they can't adequately move the food back. They get so much water, they don't know what to do with it. All they know is if they put their head like that, gravity is going to do it for them. So we use what's called a quick sip, which is basically just giving tiny sips. So giving them some jaw control. And that's why this cup is nice, because you can see how much liquid you're putting in the mouth, and just giving them little sips. So when you see a child that does that a lot, look at the volume of liquid that they're getting at one time. Tongue thrust. This is a really big one. When you all have those kids, especially with CP, sorry, my microphone, CP, who you put the spoon in, food comes right back out. And that's a very stressful, caregivers are very stressed about this. So the technique is lateral spoon, and it works really, really well. I'm using a very small spoon, but again, I can give jaw control, but I'm going to present, instead of presenting the spoon face on, because the further I put the spoon back on their tongue, that can trigger either a significant tongue thrust or a bite reflex, those kids that bite on the spoon. I turn the spoon like this, and now I have a bigger surface for their lip to feel it, and I give them some lip closure, and they learn to suck off a spoon. So lateral spoon means presenting the food like this. Give a little lip control, okay? Quick tip for kids who don't swallow or take a long time to swallow. We know those kids. Give them, you're waiting and waiting and waiting. You can tell you haven't seen a swallow. Either just give them an empty spoon, bring it up, because sometimes even that spoon touching their lips will just trigger an automatic swallow. Okay, and then difficulty chewing. Sometimes we help, depending on the texture, put the food on, we have them bite on the side so that the food is right there so they know what to do with it. This is, I'm gonna just skip over this slide. It's some feeding techniques for babies who gulp or lose milk. And again, the lip jaw support for our babies, but pacing is also important. And that's where, my baby, where you put the nipple, and even it could be the breast, and you don't take it out, but you bend the bottle enough so that the milk flow stops to give them a chance to breathe, and then move it back up so that they can suck again. We don't want to pull bottle and breast out in and out of their mouth. We just need to help pace the flow for them. This is more baby stuff. Oops, I think I went back. Okay, here's a little bit about, this slide again reiterates texture development. How am I doing, Kate? Am I okay?
Yep, you're doing fine, no worries.
Okay. I would say these are my, if you take anything away from tonight, think about the big three. Posture, what kind of control and how are you presenting the food to them? Because sometimes we can't fix, some kids, we're not ever gonna fix their tongue thrust. But we can present food in a different way that minimizes the tongue thrust, or they can learn a different skill. And then the third one to take away is always look at the diet modifications, which include the texture of the food or the viscosity of the liquid, which is how fast it flows, and the portion size. Okay, and again, this fits you. This chart shows how it fits with skill. So liquids, babies 0 to 6 months just need complete body and head support. So it tells you along the side, it tells you the type of texture, gives examples of that, what the skill is that you, so if you see a caregiver giving soft and bite-sized food, you have to go across. That child needs to have up and down jaw movement, some diagonal jaw movement, and tongue movement from side to side in order to handle that food. If they don't have that, I need to back up to mashed. So this helps think about the food texture that you can do. And I want to point out, this is and I believe, yes, there's the website. For all of you, this is the International Dysphagia Diet Standardization. And you can go to this website and they have videos for all of these levels of food and drink, and they tell you what the texture should look like. There's little videos that you can do, like the drip test for liquids and the fork mash test. So they're working to standardize this globally, and there's sections on there for adults and kids. So I wanted to point that out as a resource. And then the nutrition stuff I put in there for you to think about, because some of our kids are at high risk for anemia. And then I know I'm running out of time, but I do have a little bit of things on sensory issues. So I wanted to point out this slide about the challenges that kids have. Usually it falls in either along the touch, smell, sight, taste, and things that you could look for to help with some of those challenges. I'm going to go to, and then responsive feeding. So I'm going to kind of try to end here on the psychosocial piece, which is encouraging positive parent-child relationships and helping our caregivers, whether they're the child's parent or they are caring for that child in an institution or in a home or supporting family, we want to build their confidence. And then a little bit on behavioral intervention. So that was really fast, but again, thinking about how the child and the parent interact. So I did it, 6 o'clock. Like I said, we could continue on. Maybe there's ideas for another session next fall to elaborate on one of these topics. In this slide, I put my email and my WhatsApp. And this is, so the first slide showed my little buddy. this is him again. When he was able to sit up, he had his tracheostomy removed and he was eating solids. But you can always email me or WhatsApp me. I WhatsApp with a lot of people around the world, so I'll take questions.
Does anyone have any questions? Well, thank you so much, Dr. Rabaey. I really appreciate you coming on and sharing your expertise with us. This is wonderful.
You're welcome. And again, I know this is sort of like just really quick and dirty, but like I said, think of it as the big three. If you have three things that you take away, posture, skill, diet, or food texture, food and liquid.
All right, well.
Do you want me to, I can stop